I think we have time for a few questions. There were some really excellent audience questions. I want to get to those before we close. Rajiv, I think I'm going to let you take it, turn it over to you, and you can just go ahead and ask the ones that you felt needed to be answered.
That'd be great. You know, I think everyone did a terrific job, and it was very educational for myself in this whole process. Mohammed asked this really interesting question. Did you see any increased infiltration of inflammatory cells in the coronary walls? Julio or Renu, were there any data to suggest there's increased inflammatory cells in the coronary walls leading to a thrombotic state or increased thrombotic state?
Overall, there are cases in which you do see inflammation more, even non-COVID patients. So it's very hard to say, is there more inflammation? One would have to do a real comparison, age matched, risk factor matched, to be able to say whether there is increased inflammation in COVID. I've seen some cases in which definitely there's a lot of inflammation in the arterial wall, but I've also seen non-COVID patients with the same thing. So I can't say it, whether it is true or not.
And Renu, did you see any patients, was there any evidence of replicating virus in endothelial cells in these microthrombi cases?
No, we've not seen replicating. We've not seen in the endothelial cells. And as I said, PCR was negative in these cases, especially in the woman that Dr. Guayumi showed. We could not detect any virus in the heart at all.
Right. And look, Stephen Epstein asks a great question. Should all these patients, you think, be put on immunotherapy since the primary problem seems to be an immune response that targets the coagulation system? Should we be using more immunotherapy? And I guess that goes to the question of the use of prednisone or the IVIG that's been shown in some studies.
Yeah, I think that's a great question. I think this is a situation driven by hyperinflammation. There's no question about that. And that may be something that, I think there, as you know, there was some data with dexamethasone. It's been some controversy about it, but there was some initial data that showed it was promising. I think the immunotherapies are promising. We certainly don't want to get rid of the idea of clearing the virus, but we don't want the body to have a over-exuberant inflammatory reaction, which I think is really what the cytokine storm is all about. And that's why we're getting a lot of these hypercoagulable states. And I would follow that up by asking one question. Dr. Tunev asked a question about whether or not the implications of Dr. Ramani's talk are that really it's a thrombotic problem. It's not as much a problem of inflammation, direct virus inflammation of the myocardium. And so is antithrombotics the way to go in order to protect the heart? That's Dr. Tunev's question.
I think the answer is going to be probably yes. From a clinical perspective, I think the answer is going to be yes. And the reality is that we saw from the Mount Sinai studies that use of DOACs was very beneficial in COVID patients, not just during the peri-COVID era, but really in the 3 to 6 month time period. I wonder in patients like this, and I know we talked about thrombolytics and there was really no utility. The question is there any utility of 2B3 agents? Intracoronary 2B3 agents in these situations where you have, say, slow flow, you have a hyperthrombotic state, which you saw a lot of patients like that. Robert, Jay, what do you guys think about that?
Well, in the case that I showed, I did in fact do that intracoronary during the case, and that did help. But in that particular patient as well too, they were also high bleed risk. So, it's going to be a matter of mitigating the risk of bleeding versus the risk of thrombosis. And if you have a patient that continues to be on, low molecular weight heparin post-procedure plus dual antiplatelet therapy, do you also then consider putting them on a 2B3A? That's a lot of agents all at once, and obviously it can be problematic.
Jay, can I interrupt and ask one question?
Yeah.
In your slide, you said something about you look at the D-dimer levels after the first case you presented. It was a non-STEMI COVID-19 patient. You said, I examined the D-dimer levels, and based upon that, I was electing to put him on an anticoagulant. He refused ultimately. Where did you get the data about this D-dimer, and where's that coming from?
The problem is, so it's obviously that's controversial as well too, and that's not necessarily related to ACS per se, but it comes to the VT literature. And our protocol at our institution has been to place these patients either on low molecular weight heparin or a DOAC post-procedure if they have an elevated D-dimer on presentation. So for some of these patients, we think that they could have, obviously if they have ACS, but they could also have, a potential for VT as well. And if there's a high clinical suspicion, then we would treat them as such. And obviously, in that recent review paper that was published in JACC, that is a very controversial paradigm, and also one that's not with a lot of evidence. So these protocols, UNC does this. Obviously, Mount Sinai has also done this to a certain degree as well too. But the ACS population, obviously, then you have to balance out. Do you continue them on the dual antiplatelet therapy plus also the DOAC as well too? And what we've done, especially with COBRA, is and again we're waiting on COBRA Reduce to come out to really guide us in this, but we go with a shortened duration of dual antiplatelets and then continue the DOAC for at least a month.
And Robert, I guess I would ask you one question. You pointed out to I don't know, it was an opinion paper or what it was, that's a review paper in JACC. You were pointing to the guidelines and you were saying as yet there's really nothing that is recommended for arterial thrombosis. You said there is a recommendation of prophylaxis for venous thrombosis, which is quite clear in the COVID patients. Do you think the guidelines, Robert, are not aggressive enough in terms of what we should be doing in standardizing therapy in a situation where we're slowly learning this is more of a thrombotic problem for the heart than it is anything else?
Yeah, I think it's a great question. It's becoming clearer, I suppose. One of the things, of course, that we learned with this infodemic that accompanied the pandemic was that we should be a little bit circumspect about emerging studies and emerging data. So it's, on one hand, you've got to act rapidly and then adapt as new evidence becomes available when you plan how to treat these patients. But on the other hand, you've got to be a little bit circumspect. I think clearly there is a lack of guidance as regard to arterial thrombosis. There's a little bit more evidence, and we've highlighted a couple of times already the evidence for antithrombotics from observational studies in venous thromboembolism. But I think there is a rationale for potent antithrombotic therapies to inhibit some of the arterial complications that we've seen today. And one final comment, when you look across the literature, it does seem to be that bleeding is not a particularly strong component of the systemic illness associated with COVID-19. So it may be that there is a place for potent upfront antiplatelet and antithrombotic agents. And last thing I will say is that since we recorded, COBRA Reduce has been accepted for presentation at TCT Connect. So look forward to sharing the data with you then.
Robert, one more question for you. How does COBRA Reduce data inform us in terms of our COVID era? Does it inform us? Does it change anything for the way we think about treating COVID patients? It seems like Jay's already recommending anticoagulants on top of antiplatelet agents. Is that something that COBRA Reduce can help us sort of figure out what the best therapy is? It's a lot for a patient to be on an anticoagulant and dual antiplatelet therapy. So I'm just wondering, is that something that we can use going forward, just serendipity wise?
Yeah, I mean, there's a lot of kind of moving pieces go into that question, and Jay already mentioned it in his answer. When you're talking about prolonging DOAC therapy, then after the procedure, what do you do with the dual antiplatelet therapy? So, in some respects, COBRA Reduce will give us some insight into the kind of relative risks benefits or net clinical benefit compared with standard DES and a slightly more prolonged dual antiplatelet therapy. So it'll give us some guidance. Of course, it's extrapolation.
Rajiv, any more questions before we close? Did you want to get to anything else or not?
Oh, I think, we've answered most of the questions, and I don't think there are any pending questions. I just think that, with COVID-19, the abnormal was the norm. I mean, in other words, we saw so many things that we were shocked by, seeing the 25-year-old with having strokes, or the 35-year-old with a pulmonary embolism bilateral. So we saw it, and I think we learned a lot from our colleagues in China and Spain and Italy. And I think, if, hopefully never, but if it does come back, we'll be able to deal with it in a better way, because COVID does not treat cardiology.
Yeah, there's no question.